Hi everyone, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota. Today we're continuing our Anesthesiology 101 lecture series on day 11, OB anesthesia. We have a couple different learning objectives. First, we'll cover neuraxial anatomy, the different structures that are accessed when placing epidural or spinal anesthesia. Then we'll discuss some of the similarities and differences between epidurals and spinals, and then we'll conclude discussing combined spinal epidurals, CSEs, and then some of their techniques, advantages, and disadvantages. We'll begin by discussing some of the different structures that are within the spinal cord. These are very important when placing epidurals or using spinal anesthesia. So the first structure that we'll look at is right here. This is just the subcutaneous adipose tissue. Then as we move down here, we have our supraspinous ligament. And then we'll skip down to this one right here, which is looking right there at our interspinous ligament. And then right here, this guy is going to be our ligamentum flavum. And then right here, we have the epidural fat, runs right here. And as you can see, if this is an epidural needle, it's running in this area. So this would be our dura mater, and then right outside of it would be the epidural space, which has the epidural fat within it that our epidural needle is going into. And then here, this would just be pointing at the spinal cord. And then just to get a little bit more specific, help us see everything. If this was like magnified, this area right here, then we would have, on the most exterior, would have our dura mater, and then, so maybe our dura mater is right here. And then beneath that, we would have our arachnoid matter, and then beneath that and right on top of the spinal cord itself, we would have our pia mater. And then importantly, especially for spinal anesthesia, the CSF is going to be in the subarachnoid space. So that's going to be between the arachnoid mater and the pia mater. So between the arachnoid mater and the spinal cord itself. So the CSF contains the subarachnoid space, and that's where you would place the needle to perform spinal anesthesia. So we're going to compare and contrast some of the different features of epidural and spinal anesthesia. So epidurals are generally anesthesia techniques that produce a lower density block as compared to spinals, which have a higher density block. So most epidurals that you see for a patient going through labor don't have sufficient anesthesia for a patient to undergo a C-section, whereas spinals are kind of the standard that you'll see for patients undergoing a C-section. The caveat to that is epidurals can be updosed, and then when you increase the dose of medication in the epidural, most of the time that's sufficient for a patient to then undergo a C-section. But Generally, patients report that it's still not as good. It doesn't provide as good of anesthesia as a spinal. Um, Epidurals take about 10 to 15 minutes to begin providing pain relief. Spinals, because you're introducing that medication almost directly to the spinal cord, there's just the pia mater in between it, have an almost immediate effect. And then they produce a lot denser anesthesia or loss of sensation. So spinals are quicker. The big advantage for epidurals, or one of them, is because you're introducing a catheter into the neuraxial region and you're leaving that catheter there, theoretically, you could provide anesthesia for days. So long as the epidural continues to function as it should, then you can leave that catheter there and it continues to administer medication and provide anesthesia. Spinals, on the other hand, you introduce a needle into the subarachnoid space and then inject a medicine and then remove the needle. And these generally work for about 2 to 3 hours. So because these are different anesthesia techniques and you're targeting different spaces within the spine, you're going to use different techniques to identify the space. So if you're performing an epidural, you're going to take a needle and advance it with the stylet in place through the supraspinous ligament into the interspinous ligament, and then you can remove the stylet. So if we go back here, you're advancing your epidural needle, so we have it shown here. You're advancing it through the supraspinous ligament into the interspinous ligament, and then at that point you can remove the stylet. So here's our stylet, and then take that out. And what you would attach to it, what I've seen most commonly is a syringe attached to it, and this syringe is filled with water. And then you'll continue to insert this needle in, applying gentle pressure back here to the handle of the syringe, and you're feeling for loss of resistance in the syringe. So once you insert the needle through the ligamentum flavum, shown here, and then into the epidural space, then the epidural space it's like a space, or a theoretical space at least, that can fill with this saline. So you'll feel the plunger on the syringe go down and allow fluid to flow into there. And then you've identified the epidural space, and then you can thread a catheter in. And there's different centimeter marks on the catheter, so you know to leave about 4 to 6 centimeters of catheter in the epidural space. Sorry, that got super messy, but hopefully that idea makes sense. To identify the space to perform spinal anesthesia, similar to an epidural, first you would apply lidocaine and create like a little wheel under the skin, and then you would insert introducer needle, and then that's going to provide spinal anesthesia. You'll start in a similar manner as placing an epidural. So you'll palpate the iliac crest, which indicate the L4 vertebrae, or the L4, L5 space. And then you'll use lidocaine to create a small skin wheel just beneath the surface of the skin, just to minimize pain when you then place your needle into the patient's back. The first thing that you'll do is you'll take an introducer needle, which is just more thick, and you'll place that in the patient's back until you enter the interspinous ligament, which would be right here. And then you would take your spinal needle and you would run it through the introducer. So running it through the introducer needle, until you feel loss of resistance of the ligamentum flavum, and then you're also going to have to puncture through the dura. Um, Once you think that you've entered the subarachnoid space where the CSF is, there's this stylet at the end of your spinal needle, and you would remove that stylet and look for CSF to drain out of your spinal needle. And if you see a CSF draining out of the spinal needle, that means that you're definitely in the subarachnoid space because that's where the CSF is located. And then you could attach your syringe with your medication and inject your medication in, and now you've placed your spinal anesthesia. So, continuing on with our comparison between epidurals and spinals, uh, epidurals have a lower rate of hypotension associated with them. Um, Spinals have a relatively common rate of hypotension associated with them. It's one of the indications almost that your spinal is set up appropriately, is seeing a drop in hypotension. In Rapid City, they always have vasopressors running with their spinals because they anticipate hypotension with almost every spinal. And then I thought one good point to add would be comparing the fail rate of C-section. So, like we talked about with the density of epidurals, they can be updosed to facilitate a C-section. And when you do that, you have about 26%. This is according to a study published by the ASA, but a 26% failure rate. Of being able to perform a C-section with just an updosed epidural. I thought that seems a little high, so that could be a good point to ask our attendings about. Whereas with spinals, there's about a 6% failure rate of being able to perform a C-section. So a lot less, it's a lot more reliable for performing C-sections. So the last idea that we'll talk about is the combined spinal epidural technique, otherwise known as a CSE. It's appropriately named because you're using both the spinal and the epidural technique, trying to utilize the advantages from both of them. There's two different techniques to performing this. So one is the needle through needle technique. Using this technique, you're effectively using your epidural catheter or your epidural needle as the introducer needle for your spinal needle. And then the second is, we'll just call it separate needle. Which is kind of performing a combined spinal epidural anesthesia almost an individual component. So first you would apply or set up your epidural, and then you would go back and administer a spinal. The advantage to that is you could see and ensure that your epidural was set up appropriately before you administered your spinal. The major theoretical risk of the separate needle technique, will include this in a disadvantage, is you have a theoretical risk of shearing your epidural catheter in the patient's back. And that would be a massive complication if you broke off the catheter and left that in the patient's spine. The advantages are pretty intuitive. So because you're using both of these and you use a spinal, you're going to maintain the fast onset time of the spinal. Because you're leaving a catheter in their back like an epidural, you can still get longer duration. And then because you also leave the epidural catheter in their back, you're able to updose their epidural catheter in order to perform a C-section if needed. Where the alternative would be if you just performed spinal anesthesia at a dose sufficient for a patient to undergo labor, but not for a C-section, and then they need an emergent C-section, you wouldn't have the ability to just updose their epidural catheter. The other disadvantages of doing a combined spinal epidural anesthesia are pretty intuitive. So it can take more time because you're having to do two procedures, or like 1.5 if you're using the combined needle through needle technique. It can be more technical just because you're performing two procedures, and then it can be more invasive because you're having to do two procedures. I hope that this lecture helps you guys just get your feet under you for your OB anesthesia rotation, kind of have your bearings about you. Let me know if you have any questions. I'm sure all of our attendings would love to help.